Good evening everyone, how are you? Hope you are doing good. I am Dr. SULTHAN RASHID, consultant diabetologist at Ammaar Chennai. Today I am going to discuss about one of the important topic, that is diabetic kidney disease or CKD management in diabetes mellitus. Let's go into the topic. As per recommendation, an annual assessment of serum creatinine and urine albumin to creatinine ratio is advised for identifying, staging and monitoring the progression of diabetic kidney disease, that is also called as CKD. Annual assessment post 5 years after diagnosis in persons with type 1 diabetes or at diagnosis in persons with type 2 diabetes is recommended. Patients with DKD should be counseled about optimal glycemic control, blood pressure control and lipid control along with smoking cessation to reduce the risk of development and progression of diabetic kidney disease and cardiovascular disease. As per recommendation, renin-angiotensin-aldosterone system blockade with an ARB and AC inhibitors, they remain the choice of drug for diabetic patients with micro or macroalbuminuria to reduce the risk of DKD progression. Nowadays, SGLT2 inhibitors also approved to reduce the progression of DKD. So SGLT2 inhibitors with proven benefit is recommended as a foundational therapy for persons with type 2 diabetes and DKD with EGFR more than 20 ml per minute by 1.73 m square to reduce the progression of DKD and risk of cardiovascular disease. They are also giving GLP-1 receptor agonist to reduce the progression of kidney disease. So GLP-1 receptor agonist with proven benefit is recommended for persons with type 2 diabetes and DKD with EGFR greater than 15 ml per minute by 1.73 m square for glycemic control and to reduce the risk of atherosclerotic cardiovascular disease and progression of albuminuria. The latestly approved drug is Ammaar antagonist finerenone. They can also be given to reduce the progression of kidney disease. A non-steroidal mellocorticoid receptor antagonist like finerenone with proven kidney and cardiovascular benefit is also recommended for persons with type 2 diabetes with an EGFR greater than 25 ml per minute by 1.73 m square with normal serum potassium concentration and albumin to creatinine ratio more than 30 mg per gram despite the maximum tolerated dose of renin-angiotensin system inhibitors. Why there should be a normal serum potassium? Because these drugs increase the potassium concentration, and particularly if you are combining with AC inhibitors, the chance of increase in potassium is more. So we have to regularly monitor the serum potassium is advised. Thank you so much for your kind attention and kindly share my lecture to your friends.